Hello everyone, I'm Bambi Troxell. I'm the speech and language pathologist and coordinator for the speech and language and swallowing department here at Orange Grove Center. Today we're going to be discussing Dysphagia Overview, and we will be talking about swallowing disorders in individuals with intellectual disabilities. As a DSP, you may be asking yourself, what can I do? Some questions that we're going to address today are, what in the world is dysphagia? And what does this even have to do with me as a caregiver? This course will teach you a lot about mealtime difficulties and swallowing disorders. It's going to teach you what to look for, ways to prevent problems, and what you do when you see a problem. When working with the developmentally disabled and intellectually disabled population, there are a number of things that can contribute to many mealtime challenges. Some of the things that contribute can be weak muscles of the tongue, lips, cheeks, throat. All those are very important when you're preparing your food to swallow. Weak muscles in the esophagus, even whenever something that's normal for us for food just to, once you swallow it, you forget about it. When you have weak muscles in your esophagus, it it doesn't work the way it's supposed to, and that can cause problems. Poor skeletal and muscle development if you can't sit up correctly and have good posture while you're eating. GI disorders. There are so many factors that contribute to being unable to swallow, unable for your food to work through the GI tract as needed, and able to have a good and positive eating experience. And in some cases, it's even impossible without some type of intervention for the person to be able to complete that process. Um, when a patient is on many medications, they have behavioral sensory problems. If you're dependent on a caregiver and you can't verbalize that your food is too hot or too cold, or that you're not ready for your next bite. If you have a weak coughing reflex, something that is a protector of our larynx and our trachea, something that is an automatic function, if it's weak and it's unable to do its job, that can cause a problem. If you have a nervous system disorder, a seizure disorder, whenever you have a seizure, it just sometimes comes right out of the blue and you're unable to know when it's coming, and everything in your body just kind of shuts down. What if you have a bite of food in your mouth? That's something to think about. If you have dental issues, if you're unable to tell your caregiver that your mouth is hurting because you have a tooth in there that is maybe decaying or is about to come out. These are all factors that need to be discussed and covered whenever you're dealing with mealtime. There's a lot of factors. Did you know that mealtime issues are one of our highest areas of medical liability? So, caregiver knowledge and technique is a crucial factor in illness and fatality outcomes. A well trained administration and staff can prevent unnecessary choking, the use of the Heimlich maneuver, hospitalizations, pneumonia, respiratory complications, aspiration, and even death. We all take swallowing for granted, but it's actually a very intricate process and involves several cranial nerves that come from your brain and your spinal column and many muscles. If any one of these functions is on the blink, it can cause swallowing difficulty. On an average, we swallow somewhere around 580 times a day, most often during eating and the least while we're sleeping. So for the sake of ease, we are going to break down the swallow into three basic phases, which would be the oral, the pharyngeal, and the esophageal phase. During the oral phase, as you can see, there's a line that's pointing to the bolus. A bolus is whenever you have food or liquid in your mouth and you have used your tongue, your jaws, your palate, everything, in order to get that broken down and kind of in a moist and cohesive ball before you swallow. Even liquid can be a bolus whenever you have to get it all together and you hold it in your mouth before you swallow it. Some thicker boluses may be the consistency of a milkshake, or if you have something really syrupy like that's a honey consistency, you have to get a kind of a hold on that before you can swallow it. Once it passes the oral phase and comes off the back of your tongue, you're into the pharynx, and that's going to be the pharyngeal phase. The pharyngeal phase is when you come in contact with what's called the epiglottic flap that flips over and protects your airway. The next phase would be once you pass the pharynx, you enter into the esophagus, which is the tube that backs directly into the trachea. They're back to back. We want the food to go into the esophagus. We don't want it to go into the trachea. So when people talk about, well, that went down the wrong pipe, they're referring to the esophagus and the trachea. The trachea is your windpipe. The esophagus is what could be called your food pipe. I'm going to discuss the different types of liquid viscosity, and that would mean the consistency. A consistency is how something feels, especially in your mouth, how it feels when it's in there. You can tell how things kind of move around in your mouth. When an SLP puts a recommendation in place for thin liquids, that's also referred to as regular liquids. That means all beverages are allowed with no modification. They can have water, coffee, tea, any type of soda or Coke, juice, broth. Those are all thin liquids, and they can have those if they are cleared for thin liquids. If an SLP makes a recommendation for nectar thickened or nectar consistency liquids, then it would need to be able to coat and then drip off the spoon. So there are some liquids that are naturally a nectar consistency because they have the thickening already in them. So some of those would be cream soups. Keep in mind though, if you do a cream soup and it has chunks of something, especially in this picture, there's a picture of cream soup with chicken. If they are also on a modification where meats have to be modified, you need to take that into consideration. So I'm just trying to give you the consistency of a liquid, and you always need to follow the guidelines if it is regarding the texture of foods or liquids. So, sorry, to get back to what is considered more of a natural consistency of nectar would be cream soups, maple syrup, Ensure, prune juice, buttermilk, or tomato juice. So those are some things that are naturally a nectar consistency. Now, whenever someone is on a thickened liquid diet, it would be the recommendation would be made with thickener. So there's a lot of different brands of thickener out there. It comes in a can. It's usually cornstarch based. There are also xanthan gum based thickeners. Those are not as prevalent, especially if insurance will not buy those. Typically, insurance will give funding for the cornstarch based, which is fine. So what you would do is you'll follow the directions on the can, and it will always it will usually provide the scoop, or it will tell you what measurement spoon to use, like or a tablespoon or something like that. Always follow the guidelines, and sometimes they're a little different. It just depends on the brand that you're using, but sometimes as liquids sit and people are taking their drinks, it can get pretty thick. It's just the starch as it continues to grow. It's okay to then add a little liquid and thin that out as needed. That's why I'm telling you the guideline of letting it coat the spoon and then drip. So just always make sure that it's the nectar consistency. And if you have questions, I can always help you out with that. Just give us a call. We're always happy to provide additional training on how to thicken liquids and do texture preparation, just so you know. Next liquid that I'm going to talk about is a honey consistency or a honey thickened liquid. Honey consistency is thicker than nectar. It's going to flow off the spoon in a ribbon, just like honey would. Honey's a pretty thick consistency. So whenever you thicken it up, it just needs to flow in a ribbon. Doesn't need to be dripping. It has to flow in a ribbon, just like honey. Again, the directions will be on the cans of thicket that you are given, like any type of thickener product. And again, I want to say that if you ever need additional help in knowing how to appropriately thicken these liquids, always give us a call, and we're happy to demonstrate for you. The next consistency that I'm going to talk about is pudding thick, and it's just like it says. It's like as thick as pudding. It stays on the spoon in a soft mass, and it will plop off just like pudding. If you were to get a spoonful of Jello pudding, the little snack packs, and you would get it out with a spoon, you'd be able to plop it into a bowl. And again, let me say one more time, we're always happy to demonstrate any type of viscosity thickening, any liquid thickening that you may need. Again, please follow directions on the can of thickener that you have, and it will give you the correct directions for that. Okay, next I'm going to start in the bottom right corner with regular cut. These are diet textures that we have here at Orange Grove Center. The regular is anywhere from a 1/2 inch to 1 inch in size. It will be specified on Mealtime Instructions if you can go up to 1 inch in size, and the 1/2 inch to 1 inch diagram will always be on the Mealtime Instructions for you to be able to see. So always refer to the Mealtime Instructions to see what the appropriate size is. And if they aren't a regular texture, they really don't have any specific foods that they cannot have. It just needs to be cut up appropriately for them. Going over to the left bottom is Sub for Hard to Chew, which pretty much says in the title that foods don't need to be really too hard or crunchy or sticky. And in this diet texture, it's either 1/4 inch to a 1/2 inch in size. No pieces should be larger than a 1/2 inch. And you'll use, that knife or fork or kitchen scissors, something like that, to prepare it appropriately. And again, the Mealtime Instructions will specify specifically what the size needs to be and what you can't go over. The Mealtime Instructions also will always have on the opposite side some texture guidelines and recommendations of foods for pureed, make-soft, and Sub for Hard to Chew. So you'll have those to refer to. Let's go up to the top on the right side, and we're going to talk about mechanical soft texture with ground meats. In this texture, the food pieces are getting much smaller. The foods have to be much softer and easier to break down. These would be foods for people that are not doing a very good job at chewing. They may have some, weak oral motor skills. They may be very unaware of how their food needs to be chewed up in their mouth, even when you prompt them and you try to get them to chew. So in this, we really want to make sure that the food is chopped up small enough to where if they're not doing extra work chewing it up, that it's not large and it doesn't have to be chewed up quite as much, but it still does need to be chewed. Let me reiterate that. They still need to be chewing if they're able to chew, and that's something that you'll be working on with Mealtime Instructions, is prompting them to chew, giving them that visual prompt of, showing them you need to chew that up. You're doing a really good job. Work on building them up and making them really work hard at having successful mealtime and oral motor skills. So in this texture, all the foods would have to be a 1/4 inch piece, which is pretty small. So typically we'll tell you either to use a chopper, like a food chopper, or a food processor. And if you put it in the food processor, it's important to have a distinction. It is not supposed to be pureed smooth. It's just supposed to have be cut up into 1/4 inch pieces, and it's supposed to have more texture to it. So if you pulse it and you make sure it's in the 1/4 inch pieces, but like I said, you can use a chopper, you can even use a knife. It's just a lot harder to break it down with a knife. So typically we say use a food processor because human error is not quite as prevalent when you're using the food processor. Um, However, the ground meats have to always be put in the food processor and ground up to a 1/8 of an inch. That's really small. So maybe like the size of cottage cheese, really small. And it needs to be really moist. I'm sorry, needs to be really moist. You might need a binder, which means if it's really soupy or liquidy when they put it in their mouth, then it's hard for them to get that together, as you know, the bolus that we talked about. Mix it with mashed potatoes, mix it with gravy, mix it with some type of condiment. But once you chop the foods or you use the food processor to make sure it's 1/4 inch pieces, and then you make sure that your meats are always ground into 1/8 of an inch pieces, it's okay to mix those two foods together. Try to avoid mixing the sweet and the um, savory foods as preferred. If it's something that they prefer to mix all their foods together, that's okay. But you always want to ask if the individual wants that to happen, and you can always call us for additional information on that as well. Let's go to top left, and we're going to talk about pureed, and that should be pureed smooth, no lumps. And it's a pretty visual picture, pudding or applesauce, that type of consistency. That means you'll put it in the food processor and you will grind it until it is pureed smooth. So it's going to be, whatever food you choose to put in there that's easily broken down in a food processor. If you have something that's really hard to break down that has skins or meat gristle or something like that, that's not appropriate because it's going to have to be smooth and no lumps. Again, let me reiterate that there are texture guidelines and texture recommendations on the back of all Mealtime Instructions, and you can refer to those guidelines and always ask us questions because we're always happy to help. And we can always demonstrate all of these texture consistencies for you. I want to add that if liquid consistencies have been modified, that your oral hygiene and your pill administration may need to be adapted as well. And we have Orange Grove Healthcare for the individuals that have that as their PCP. We have Dr. Gannon, if she is the in-place dentist for your individuals. If it is not Orange Grove providers that your individuals have, then this needs to be addressed with their PCP or their dentist. So that would be a question for the ISC to make sure that everything has been addressed. And I can always help you with that. Just let me know. I wanted to reiterate again on the medication issue. Excuse me. This is a frequently an issue that is noticed first by direct care staff. If there's a medication mismatch with the food texture, it needs to be brought up to the physician's attention for directive. We cannot simply crush pills to assist because some pills are contraindicated for crushing. That means that it could really hurt someone, especially if they have an extended release pill. Not all pills can be crushed, and you should never, ever alter a pill unless you have gotten an order from the medical professional, the PCP, the physician. Don't ever alter pills without getting with them first. There are different sprinkle and liquid forms of many medications which your physician or pharmacist may be able to adapt to, or they may prefer the individual remain on their pill form of medication. The physician does, however, need to be aware of the concern and define the medication administration. So let me reiterate one more time. If there are difficulty with pills, then the physician or PCP needs to be made aware of that immediately. No alteration unless it is in order by the physician. Okay, we're going to talk about some things that can go wrong during meals and snacks. Number one, food can totally block the airway. That trachea that we were talking about, the windpipe, that little, it's about the size of a pencil, the esophagus that backs up to it. Those pipes are side by side. So if you swallow something and you're not prepared to swallow it, it's too large, the individual's not paying attention, the individual didn't chew, the individual's having a behavior. If they swallow that and it blocks the airway, it can cause asphyxiation, which is more commonly known as choking. Another thing that can happen during meals and snacks is aspiration. And aspiration is the ingestion of any type of food, liquid, saliva, or other materials into the lungs. That can definitely be a problem. I want to add that some individuals that you may be working with or work with in the future may have what is called pica, and that is loosely termed, they might eat just about anything that they can find. It doesn't matter if it's appropriate or not. They just have a compulsion to want to eat whatever they can find. Some of these things may be particles of cigarette butts, sand, small stones, and these are also things that can cause one choking or aspiration. And we definitely don't want a lot of that getting into our lungs, because that can really set up for infection, which leads me into my next slide. When food or liquid is aspirated, which when it goes down the wrong pipe into the lungs from the airway, it can cause pneumonia and it can cause other respiratory complications. And this picture is pretty good at showing. Do you see the yellow looking pussy liquid that's setting up in the alveoli, in the airway, in the lungs? So that's definitely prime infection breeding grounds, which can be really hard for our guys to clear, to get that up. A lot of our individuals will suppress coughs. They don't necessarily understand when you ask them to blow their nose or to spit it up, like when you were younger and you had that phlegmy kind of croup and you would hear your mom say, spit it up, spit it up. That's not always something that our individuals understand or even really know how to do. So when they get something into their lungs, into their airway, and infection sets up, it can be really hard for them to come back from that, especially if they're non-ambulatory, if they're in a wheelchair, if they have to stay in the bed a lot of the time, if they spend their day being positioned because they can't walk on their own. It's going to be harder for them to come back from any type of respiratory complication. I also wanted to mention this stat because I think it's important for our staff members to know that respiratory disease is the most common cause of death for those with severe intellectual impairment. That is a pretty profound stat for our population. So keep that in mind, that mealtime safety, snack safety, anytime they're eating or drinking at all, it's important for them to be doing what has been prescribed. So another note about aspiration is positioning, reflux, anything. I know that you're going to get into looking at individual ISPs and looking at different mealtime instructions, and you're probably going to see GERD written on several of those, and that is gastroesophageal reflux disease, which most of the time means that they have some type of acid reflux, which we're all aware of. If you're young and you don't know what that is, you probably will in the future, or you're someone that you know has dealt with it. A lot of our individuals do struggle with GERD or reflux, and it is important for them to be sitting upright when they're eating, which will be addressed on their mealtime instructions as well. And if they have acid reflux or GERD, they don't need to just lie down after they eat. They need to remain upright. Sometimes they have specific instructions from their GI doctor or their PCP, but in general, they do not need to lay down at least for an hour after they eat. So just keep that in mind. What happens whenever you have acid reflux or GERD and you lie down is the stomach acid from your stomach will come back up your esophagus, and it can sometimes enter into your pharynx, which remember I told you in the pharyngeal phase is where that very important process happens, where your airway is protected when you swallow. If you're unaware of a swallow about to take place and you're unprepared for that and you lie down and that acid comes back up, it's either going to go one of three places. It's going to work its way back down your esophagus because you have stopped that gag reflex. You have stopped it, and it's just going to work its way back down. It's either going to do that, or it's going to come out your mouth. You're going to vomit it, or you're going to try to stop it somewhere in the middle and realize it's coming up, and you don't catch it quickly enough, and you're going to cough, 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 hopefully protecting your airway. But if some of that gets through, it's going to enter your airway, and it's, first of all, it's going to burn. It's not going to feel good. Your voice is probably going to be hoarse and scratchy, and you're going to feel that burn because it's acid. And if that gets into your lungs, then that can also cause infection, which again can lead to aspiration pneumonia. So always follow those guidelines when you see that they need to be upright, because it is very important. Even if someone does not have mealtime instructions, we work with a population that sometimes struggles from day to day. They may have excellent mealtime skills, and then maybe one day something goes wrong, and maybe they're not feeling well, or maybe they got in a fight with their favorite friend. Maybe they need a little extra help that day. So it's always important to just know the general aspiration precautions and know what symptoms and signs you're looking for, so you'll have an idea of what you need to do. I want you to know the signs and symptoms of possible aspiration. Um, the list is not all inclusive, but these are some signs that there may already be trouble. These need to be happening during meals and snacks. If it's something that's happening all day, every day, that also needs to be addressed, but I'm looking specifically for things that happen around meal and snack time. So there may be a wet or gurgly vocal quality, and that can mean like a whenever you maybe have been sick for a while and you know that your voice doesn't sound normal. That would be a gurgly. You can hear it kind of gurgling. Any coughing, throat clearing, that mealtime runny nose and eyes, whenever every time you eat and your nose starts to run or your eyes start to run. If you're crying during meals, and that might mean that it hurts or it something's wrong every time that you take a bite or a swallow. Any type of changing in breathing. If you're making a facial grimace, like a really bad face every time you take a bite, these our individuals may not always be able to verbalize things, but you can read their body language and their facial expressions. If there's reddening of the face and sweating while you're eating, that's not a typical behavior while you're eating. If you're gagging or choking every time that you eat, absolutely. If you're gagging or choking, we have a choking protocol in place at Orange Grove. So we definitely need to be monitoring for that. But I would be talking about maybe not necessarily choking in the sense that your lips are turning blue, but if you're just coughing, 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 sometimes people say that they maybe had something stuck in their gullet or they got strangled. Those are things that I hear sometimes from people when they say that they were choking. If there's unusual mealtime behaviors, if every time that you call that person to come have a meal or a snack and they avoid it, or if they used to really enjoy eating and now they're trying to delay having their snack, that's not normal. If they refuse meals altogether, they just even act out or have a behavior in order to refuse that meal, or they just go and throw it in the garbage can. That's not normal. So those are some things to be looking for. Those are all avoidances of eating. Also, such a thing as silent aspiration. It may not be something that you can necessarily see the common signs and symptoms of, but sometimes if there is silent aspiration present, you will see maybe several cases of pneumonia, unexplained fevers that come and go, multiple respiratory infections. If someone's losing weight and you can't really figure out why, maybe even a refusal to eat or drink because the person feels bad after they eat or drink, although they're not showing the typical signs and symptoms. Those would be some things that you might see. And of course, you would need to make a referral to your primary care physician for this individual, their primary care physician, or to the speech department. General aspiration precautions that can be used with everyone include correct positioning, sitting upright with at a 90-degree angle. A lot of the times, a straight back chair, just a regular dining table chair. Arms are always beneficial if the person is kind of a loose sitter and they need that extra support. Of course, physical therapy can also help with additional positioning needs. You need to have a knowledge of high risk choking foods. I'm going to go over that in a little bit. You need to be aware of sensory overload. You need to set up a good environment for meals and snacks. Everybody wants to have a good environment when they eat. And good oral hygiene is very, very important. Let's look at these things. Okay, I think we just talked a little bit about positioning, that sitting in an upright 90 degrees position. You want your hips straight, level, and to the back of the chair. We want to have that arm and feet support. Sometimes our individuals may be shorter and they may need like a block or a little stool underneath their feet so they're not dangling. So they have that better feeling of being secure and not going to fall off the seat and sitting upright better, because if you're unable to touch anything below your feet, you're going to slide more easily in a chair. Staff, you need to be aware of your position if you're assisting. You want to stay near eye level and you want to sit diagonally or across so you can present the food and liquid, so you can present it to the center of the tongue. You don't want them having to turn their head to get to the spoon. You're going to be the one that's presenting food to them, so you want to make it easier and go straight towards them so they're not having to do a lot of the work while you assist them. You want that food to be presented at a straight line so the person doesn't have to, you know, have food hitting just one side of the throat. Okay, I'm just looking at my notes. You don't want to be directly beside, because this sometimes elicits an old reflexive response of fight or flight when someone is in your peripheral vision. So if you don't want to get whacked in the face, you definitely want to be in a good position for them. That support for the arms and feet, let me reiterate, if the legs don't reach the floor, you're going to have to find a way to provide support, because that's going to stabilize the entire body, including the jaw. You won't, if you're not stabilized, your whole body, and a lot of our individuals have sensory issues as it is, so you definitely want to provide all the support that you can for them to make it an easier experience. Okay, these are some high-risk choking foods. This list came from DID, and they have said that many of their incident reports that they receive involve one of these foods that are listed. So take a minute to look at all that. You want to be aware of foods that are more likely to cause a choking concern, because it helps to heighten awareness, and you want the presentation of any of these foods, if any, to always be correct. Let's see. Adaptation for a lot of these foods is possible. However, let me reiterate, you always need to refer to what is appropriate for each person's diet texture recommendation, and we went over that earlier. And there will be, the texture guidelines for you to have and refer to. Several of our individuals may not be able to have some of these foods, even if they are adapted appropriately, because they're not adaptable for their diet texture. So there's just several things. Now, if they are able to have it adapted and it's something that's maybe dry or this needs to be moistened, if you had crackers and they're really dry, what we recommend is mixing them in something. If they have, tuna salad and crackers, break up the crackers appropriately and mix it in with the tuna salad. And we can talk about those as the questions come up. But I do want you to be aware of these high choking risk foods. Some people can do just as well with these foods as you and I, but they can be dangerous for other people. Okay? Okay, let's take it all the way back to kindergarten, early elementary, and let's remember those five senses that we had all the songs about in school and Bible school. So we've got smell, touch, taste, hearing, and sight. So I want you to think for a minute about all the ways that you use those senses when you're eating. You definitely use every one of them. I'm going to go ahead and go to the next slide because I keep talking about it on one slide and then the next slide hops up. So just keep those five senses in your mind. If we have difficulty with sensory processing, and sensory processing is a lot, and if you do not have any type of disordered sensory processing, you may not understand. But our individuals that do have difficulty sensory processing are working on all pistons at all time, and they're really having a hard time controlling everything that's coming at them. So discriminating the incoming information is sometimes difficult, confusing, and exhausting. So if you're already sitting there dealing with all that, and then you add in mealtime or snack time, that's one step. But then guess what? Miss Bambi put mealtime instructions in place, and it is my job as a DSP to follow those and to give you prompting as needed, tell you to slow down, tell you that you're going too fast. So that can be overwhelming if it's taking you time to process everything. So here's some things that might be a good idea. We want to help decrease the sensory processing overload by setting up a good environment. We want to avoid that chaos and distractions during meals. So there are distractions such as the TV blaring behind someone, or staff holding an animated discussion in the peripheral vision of someone during lunch. That can cause them to turn their head and body repeatedly. That also causes changes in body position. It blocks off one side of the throat during swallows. It causes a lack of concentration, which we need them to be focused on the task at hand, which is eating. You can not talk or laugh at the same time that you're swallowing because one act causes the vocal cords to be open and one causes them to be closed. Therefore, staff have to remain aware when they are assisting during meals, not to unknowingly contribute to a choking risk by placing food in someone's mouth and then telling them a joke or asking a question, for instance. Good oral hygiene is always critical for this population. However, I feel like it's often overlooked. Bacteria can build up in the mouth, bacteria can be aspirated, and it can make people sick. And pocketed foods can cause a choking event. We need to be really diligent in working with our individuals' dentists. Dr. Gannon here at Orange Grove is a great resource. And we need to make sure that these people are getting the oral care they're supposed to have, brushing their teeth at least 2 times a day. In some cases, it might need to be more than that. They need to have their mouths checked after every meal and snack to make sure that they're not pocketing foods and that everything's okay in there. They're not always able to tell you if they have tooth pain or if something is wrong inside of their mouth. So we need to be checking their mouth and make sure everything's okay in there. To include this slide because we do work with an aging population, and it's important to know that everything changes as you age, including swallowing. Difficulty at mealtimes often increases with age, as does a lot of things. The average age of onset of the beginning of the decline began at 33 years of age. Some of you already might be past that. 75% of subjects in a 10-year study showed that more signs and symptoms of feeding and swallowing disorders and had more serious difficulties as they aged, which makes sense. Some factors that may indicate an increased risk of swallowing difficulties physically may be the difficulty chewing, vomiting after meals, throwing head back to swallow, swallowing food whole, pocketing food, a low level of alertness while eating, taking more than 30 minutes to complete a meal, if you're losing fluids or foods by mouth consistently, if you're drooling. Behaviorally, if you're swallowing large amounts of food rapidly, if you're drinking large amounts rapidly, if you eat non-edible objects, if you're hoarding foods for later consumption, if you're taking foods when no one is watching, if you're quickly grabbing food from plates or counters. Those are all indicators of things that can lead to choking and or aspiration. So we definitely need to be aware of those. We need to document those, and we need to go to the PCP or the speech therapist to get some help. Some of our individuals have issues with rate and bite size during meals and snacks. Why do some individuals take such large bites and eat so rapidly? Well, a lot of it can be judgment issues. They're not always able to self-monitor and make good choices. They may have those sensory issues that we talked about earlier, and they're just trying to get through the meal and get to the next best thing because they just don't want to sit at that table and they don't want to hear one more thing. And if they hear somebody's fork scrape that plate one more time, they're going to scream. So they're trying to get out of there. Some people just have a habit that they've formed over time, and we discussed how things change when you age. So we've gone pretty quick and done pretty good for all these years, and then all of a sudden our muscles in our throat have betrayed us and things aren't going down as easily. So we got to break that habit and train a new behavior so we can be safe. Some clients may tolerate a more rapid intake better than others, but this is a very critical thing, and it can be dangerous if it's not addressed. So what are some of the things that me, Bambi Troxell, a speech language pathologist, can do to help you? Well, some of the things that I can offer are a clinical swallowing evaluation, which is an assessment that I'll do chairside with our individuals and watch them eat a meal or a snack and ask a lot of questions and listen to some things, watch them, and make some determinations. If indicated, I might send them to the hospital to do a modified barium swallow study, and that would involve an x-ray of them eating or drinking live, and they can actually see inside what's going on if there's any type of abnormality or dysfunction there. I can make modifications, and I can develop strategies to assist this person in mealtime safety and success. I can then observe them to assure that that functionality remains, that they're doing a good job, or if something changes and they decline, I might make additional changes to ensure safety. Sometimes I might make other appropriate referrals if I am working with someone and I see that something might be, maybe not in my scope, but I can tell that maybe it might be an appropriate referral for the PCP or maybe the gastrointestinal doctor or the ENT doctor, and I can make those referrals as needed. I can write mealtime instructions, and we will train designated trainers on those mealtime instructions so that there are always designated trainers in place to train staff on the mealtime instructions for each individual person. Sometimes we might make adaptive equipment recommendations, and those include spoons, forks, cups, plates. This might be something that the individual needs to have mealtime success. Sometimes we give out, for instance, two handle cups that have an embedded opening, and that helps someone to have that has tremors to have the ability to grab the cup from both sides, to have a better grip, to kind of have more stability there, and to get it to their mouth with that embedded lid so that the opening's on the inside and they can control it a little bit better. I might make a recommendation for a smaller spoon that's more durable for someone that may bite on their spoon or take way too big a bite and they need a smaller bowl spoon. So I'll give them something smaller so they can not pile it up quite as much. But in my experience, they find a way. So that's why we still have to have eyes on our individuals while they eat at all times, so you can provide assistance as needed. Always ensure that mealtime instructions are being followed. We want to make sure that staff and caregivers have been well trained on any specific mealtime instructions. You have the right to be trained on mealtime instructions before you work with anyone. You should always be trained before you work with anyone. So you always need to let your supervisor know that you need training on someone's mealtime instructions. It's on every mealtime instructions at the top that if you have not been trained, you do not need to work with this individual. I want to reinforce that staff and caregivers should never change an item or just decide not to follow certain parts of a therapy plan, which would be my mealtime instructions for that individual. If you have concerns, you can always come and talk to me and we can discuss. If you think that someone is doing better, that's wonderful. Come and let me know and we'll look at it and make any needed adjustments if there are, if it's indicated. Again, if someone is declining and you feel like their mealtime instructions may not be as effective as they once were, I want to know that too because I want the person to be as successful as possible. I want caregivers to understand why mealtime instructions were written and how to prepare foods appropriately. So, if you are to become a designated trainer, I want you to make sure that staff understand when you're training them, and I also want you to encourage questions. And if you are training to be a DSP in orientation, ask those questions. Don't ever be afraid to ask questions to your designated trainer or to your supervisor, or let us know, and we're happy to help. We are almost to the end. I just wanted to talk about some tips if your patient is refusing to comply. I want you to consider, how does the food look? I know that sometimes as caregivers, we may have a negative reaction to how food looks once it has been prepared appropriately, especially the lower textures of mechanical soft with ground meat or a pureed texture. I want you to always display a positive attitude about everyone's food. I don't want you to look at their food and like make degrading remarks about it, or snarl your nose or laugh about it or say, I wouldn't eat that. That looks awful, because our individuals are listening and they are feeding off of the attitude that you are presenting to them. So have a respectful attitude. These individuals are on these textures because they need to remain safe during meal times, and their food is going to taste good to them if you prepare it appropriately. And I also wanted to mention, you might want to make sure it has good flavor. There are different things that you can do to make it look better, that you can, don't just plop it all in one place on the plate. You want to fix it appropriately, just like everybody else does. A lot of times I will say, oh, that looks so good, I wish I had that, because you want them to feel good about what they're eating. they may already be looking and noticing that everybody else's food looks differently, but you need to make them understand your food is the same. It just has to be fixed differently to keep you safe, because we care about you and we love you and we want you to be safe during meal times. So just be really positive in how you present things, because you want things presented to you in a good light. You wouldn't want anybody being rude about your food, or, saying, ooh, yuck, I can't believe you eat that. We don't need to ever say things degrading like that to our individuals. If there is still a problem and there is consistent refusal, non-compliance with mealtime instructions, always notify the SLP or PCP, like I said, and we will get them back in and we will try to find a solution, because mealtime success is what we're working towards. Again, I want to say, do not prepare or provide foods that are not consistent with the mealtime instructions. And we have made it to the end. These are the listed references. And again, this was adapted. I adapted it from the presentation that does for dysphagia and mealtime planning. So, okay, thank y'all.